Hello, everyone. Thank you so much for joining us for today's webinar. Today's presentation is called The Ins and Outs of Medication-Assisted Treatment in Recovery for Opioid Dependence. My name is Misty Story, and I'm the Director of Training for NADAC, the Association for Addiction Professionals. Today I'm flipping roles a bit and will not only be your organizer, but also your presenter. I'm so happy to have the opportunity to bring forward this education and address this most important topic, so thanks for joining us. So before we get started, let's review just a few housekeeping items about how you can best participate in today's webinar. The tool we're using today is called GoToWebinar. The GoToWebinar control panel you see on the right of your screen can be minimized and expanded by pressing the orange arrow. Doing this will allow you to see your entire screen during the presentation. You can always reopen it by pressing the orange arrow again. This presentation is being recorded and will be posted on our websites for later viewing. I will send you a link to this recording later today if everything goes as planned. If you're using your computer speakers to listen in today and are having trouble getting the volume higher, I recommend switching to a telephone line. We have no control over the volume output, but this switch seems to solve most problems. All attendees for the live broadcast have entered in listen-only mode. This means that your microphones are muted, so we will not be able to hear you during the presentation. However, you have the ability to send questions to our staff or to the presenter through the questions pane during the presentation. Simply type in your question and click send. Due to time restraints, we will not be able to answer your questions live during the presentation, but we will collect your questions and post answers on our website. Also during this presentation, you'll be asked to participate in some audience polling questions. To respond, simply click on the answer of your choice that's on your screen. We're going to go through these pretty quickly, so try to be ready with your computer, able to answer those questions. And if you miss one, there'll be another one that comes up shortly. The PowerPoint slides for today's presentation are located on either website that you see on your screen. And for live participants, it's already been placed into the chat box for you to directly click on that link and for your convenience, download those PowerPoint slides and move along with the presentation. Just as a personal note, I was the developer of this curriculum for NADAC, and we've made every attempt to try to put as much information on the screen as possible. That way, when you print the slides, you're able to follow along with the presentation and absorb the material without having to feverishly take notes and make sure you get everything down. So a lot of what I'm saying will be on the screen, but I'm going to try to enhance it as much as I can while still giving you a quality presentation within our time frame. Today's webinar is hosted and produced by NADAC, the Association for Addiction Professionals, and in partnership with Orion Healthcare Technology. The education delivered in today's webinar is free to all professionals. If you wish to receive CE credit for participating, you must pass the online CE quiz that's located at either web address on your screen. 1.5 CEs are free to NADAC members and AccuCare subscribers who participate in this webinar. And non-members of NADAC and non-subscribers of AccuCare receive 1.5 CEs for $20. This includes everyone, those who are logged in today for the live event, as well as those who have downloaded the archive version. Either way, you are eligible to receive CE credit for participating in this webinar. And this webinar is approved by NADAC and NBCC and OASIS and is accredited by the American Probation and Parole Association. After you pass the online CE quiz, a certificate of completion will be emailed to you within 21 days of submission, although it's usually much quicker than that. So just to be crystal clear out there, successfully passing the CE quiz is the only way to receive a CE certificate. And I don't want to bore you with my short bio and tell you all about myself. You can see that on the website, or maybe you've interacted with me in the past. And I just would rather use this time to deliver some of the rich content that I have planned for us today. So if it's okay with you, I'm going to go ahead and dive right in. So as I mentioned at the very beginning, I really hope that you're able to sit back and just absorb some of the information that I'm saying. We're going to be talking about a lot of really technical terms, a lot of things that, a lot of words that might be new for you or might be complicated. I would love it if you could just sit back and really just try to take in the words that I'm saying as opposed to trying to get down every single detail that I'm saying. If you can walk away with an overall gist of the presentation, I think that that will enhance your practice more than anything. And then, of course, we're hoping that these PowerPoint slides will be used as a reference for the future to allow you to go back and regain some of that detailed knowledge that you can on a second swipe. So with that said, let's go ahead and just dive right on in and start talking about opioids and opioid dependence in general. And you might have been on some of my previous webinars or previous educational materials that's been developed by NADAC and are familiar with my flow, but for all the newcomers out there, I want to tell you a bit about how I present material. But I'd like to start off just giving an overview of the basic information, and that will build on some medium information and then move to the more advanced information. So just bear with me over the next hour and a half together, and I think by the end you'll have a really clear picture, but you might not see where we're going at the beginning. But you'll see me referencing that we're going to touch on one certain topic just a little bit, and then we'll dive into it more in depth as time goes on. But I promise I'll give you a whole package by the time we're finished. And since I'm giving caveats here at the beginning, I'll go ahead and give you another caveat for NADAC, is that just to tell you the purpose of why we're having this educational seminar today. And it truly is just to provide some useful, unbiased information concerning the medication-assisted treatment for opioid dependence, so your clients are afforded the best available resources and options for their treatment. I do fully understand there's a lot of strongly felt emotions out there by lots of different professionals regarding medication-assisted treatment for opioid dependence, and some of those are really founded, and some of those are myths, and some of those need to be debunked, and hopefully we're going to get through some of those today and give you a different perspective on the purpose of medication-assisted treatment for opioid dependence and for what clients it really can be appropriate for. We are going to talk a whole lot about some detailed aspects of medication-assisted treatment, and we're going to be talking about like the appropriateness of use and the special precautions for each medication, what happens if you miss a dose and the side effects. And just as a reminder, depending on your professional license or maybe your credential, many of the things that we're discussing today are beyond the scope of practice for most counselors, since most counselors don't have prescribing privileges. So I really encourage you just to use this information as a quote-unquote information only and as a resource for educating your clients and their families and sometimes even prescribers, but making sure to do that within your addiction professional scope of practice. And again, it's really important that addiction counselors in general know about medication-assisted treatment as much as possible because, let's face it, you guys are the ones that are seeing the client most often. And you're able to recognize those possible danger signs or maybe those abnormal side effects and even able to monitor compliance and report that information to the prescriber. So as you can see from that big giant black box at the bottom there, we want to make sure that all addiction professionals always direct the client to his or her prescriber if any of these questions or concerns arise regarding prescribed medications. That's for the ones we're discussing today and for all the other medications that your clients might be on. Because it is outside of your scope of practice, those types of things need to be mostly discussed with a prescriber, but you are the frontline clinician that sees them often. So if someone reports to you that they just doubled up their dose, for example, of methadone, is that okay? You can have some knowledge in the back of your head to first say, well, I really want you to go talk to your prescriber, but here's what I know about it, and then continue to instruct them to go to the prescriber. So that's my big caveat before we dive right in. So starting with the most basic topics that we can is just what are we talking about when we say opioids or opiates? And so just to be super clear about that, regardless of the type of the opioid, whether it's naturally occurring or it's synthetic, each opioid works in the brain in the exact same way. And it can be divided into three categories. So it would be agonists, partial agonists, and antagonists. And we're going to talk about each of those three categories. Regardless of whether it's heroin or OxyContin, those all fit in the same category and affect the body and the brain the exact same way. But something like Naltrexone affects it in a different way, but again, within these three categories. So let's talk about agonists first. In general, agonists activate the opioid receptors. That's what they do. They just activate it. They don't do anything else beyond that, just activating the opioid receptors. And then by activating those opioid receptors, it in turn causes these physiological and psychological effects that you're most commonly see with your clients who have active opioid use. And so as you can see, based on all of the bullet points there in red, these are all of the effects that taking an agonist would have on an individual. So think about that person that's out there taking heroin or OxyContin, for example. It's not surprising that they would have pain relief and euphoria and that bobbing head, also called nodding, and the warm flushing of the skin and the face and the neck and the chest, and then those iconic constricted pinpoint pupils. Those are something that is really obvious for an individual who has taken an opioid agonist. So as you can see, that's a whole list of all the effects that is naturally going to be occurring for anyone who takes an opioid agonist. And then it will continue to increase those effects until the receptor is fully activated and a maximum effect is reached, even if that's death. We'll talk about that some more. And all of the opioids that you generally think about being street drugs, all of them fall within the agonist category. And they can be administered many different ways. You can see them all listed here on your screen through injection or smoking. Maybe they're snorted. Maybe they're in a pill form. Lots of different ways to get these drugs into the body, but they do affect the body in the same way. And depending on the type of drug that's going into the body, the duration of the effects can last anywhere from 3 to 6 hours, for example, with codeine, or 12 to 36 hours for methadone, for example. And so that's why people say that there are short-acting opioids and long-acting opioids. That really has to do with the length of time that it's activating those receptors and causing that physiological effect of all the different things that were listed in red on the slide right before. So here's some examples of some opioid agonists. So there's opium, just as the most naturally occurring form. Then there's morphine and codeine. We've got heroin and hydromorphone, oxycodone, hydrocodone. We've got Darvon or Darvocet. Also, we've got Demerol and fentanyl. Methadone is also an opioid agonist. And then there's also LAM or Orlam, which is a synthetically manufactured long-acting opioid, but it's no longer being manufactured in the United States. So all of those are examples of agonists. And all of those are also things that are being diverted on the street and are being used as drugs on the street. And they all fall into the opioid agonist category. That's going to be important as time goes on, but I'll continue to revisit these topics over and over again until they sink in. So don't feel like this is our only opportunity. So now let's talk about some partial opioid agonists. So partial opioid agonists share some of the characteristics of agonists in the sense that they activate opioid receptors. And then if they activate the opioid receptors, they're going to cause those same physiological and psychological effects that we talked about in red on those first few slides. And we know that those are most commonly associated with opioid use. And so at low doses, partial agonists and full agonists resemble one another. But this is how they're different. At high doses, partial agonists do not produce as great of an effect as full agonists. And this is a phenomenon known as the ceiling effect. I'm going to touch this many more times as the presentation goes on, but I want to introduce it right here because this is the main reason buprenorphine has come onto the scene and why it's so important for opioid dependence treatment at this time, is that buprenorphine is one of the partial opioid agonists. And so it is able to act similarly to an agonist with low doses, but acts very differently at high doses. So I'm going to show you what that looks like a little bit further on. And so then our last category is opioid antagonists. And these are the exact opposite of agonists. So they're antagonists. And so they work by also binding to those opioid receptors, just like the other two categories we talked about. But they do not activate them at all, like the full or partial opioid agonists do. Antagonists actually do not cause any psychoactive effects. You know, example is euphoria or pain reduction or that nodding or pinpoint pupils. None of that happens at all. But instead, those antagonists occupy those opioid receptors and then block the effects of any competing agonist. And so what does that mean? It means basically they're sitting on that receptor, and if any other agonist, such as heroin, comes along and they want to get high off of heroin, there's already one of these opioid antagonists that's sitting on that receptor, and heroin will not work. There'll be zero effects of heroin. And that's really important when we start talking about the effects of buprenorphine, for example, later on, because it's going to make it so someone cannot get high off of this medication if they wanted to. So two examples you might be familiar with for an opioid antagonist, the first being Naltrexone, also commonly known as Narcan. You might be familiar with that in your practice. And then the other one is Naltrexone. It's also known as Revia or Depade. Just as another important note here is that neither of the medications here, Naloxone or Naltrexone, are derivatives of the opium poppy, but they're designed to mimic the chemicals that bind to the opioid receptor. So they're not actually opioids. They're just opioid antagonists and do not come from the opioid poppy. So here's a visual of what I just now described. So when we're talking about full agonists, when someone ingests a full agonist, such as methadone or heroin or OxyContin, It binds to the opioid receptors, and the more that they take, the more effects that they have, and it just keeps going on and on, up and up, until possibly death if they take enough. Then for partial agonists, such as buprenorphine, right here you can follow my cursor moving along the line. When a partial agonist is ingested at a low dose, it gives you those effects just like it would with an agonist, but as it gets to higher dosage, the ceiling effect comes into play, and the effects do not get any higher than a certain baseline. And so that's one of the benefits of a partial agonist over a full agonist. And then conversely, talking about antagonists, which is naloxone or naltrexone, when those are taken, it binds to the opioid receptor. Absolutely no effect is felt, no matter the dosage, and they continue forward. Again, no matter the dosage, no effect is put into the system to make it have some psychoactive effects or physiological effects that we described at the beginning. So that's a basic overview of the three different categories of opioids that we're talking about. So just continuing on into the psychopharmacology of opioids, which I personally think is the most fascinating part of this entire presentation, but I'm a little biased towards that myself, is that in order to understand how opioids affect the brain, we think that we need to basically understand some basic brain functioning. And so I'm just going to start very simply at the very beginning here, just talking about how psychoactive chemicals affect the body. And so that's done through the central nervous system, which consists of the brain and the spinal cord. And as you probably know, the central nervous system is primarily responsible for things like thinking and learning and judgment, all of our emotions and our voluntary movements and our sensory inputs. So if you think back to any drug that's being used illicitly on the street, of course, it's affecting things like thinking, learning, and judgment, and all of our emotions and those voluntary movements and our sensory inputs. That's what makes the drug work, and why it's so addictive is because it's modifying those components of our central nervous system in a pleasurable way, causing people to want to do it some more. And so that's the basic 101 of how drugs affect our brain. And then to go a little further, we know that the human body has a whole massive system of how it responds appropriately to the outside world. And so it manages itself by having these rapidly sending signals, also known as messages, also known as neurotransmitters, to billions of little neurons that are located throughout the entire body. And so as I said, these messages are also known as neurotransmitters, and they instruct that neuron to take some action. And so we know that neurons are most commonly referred to as the building blocks of our entire nervous system, and each one of them has their own shape and their size and function that tell that neurotransmitter, or that tells that neuron what types of neurotransmitters that it can receive. And that's important because it's going to come into play when we're talking about agonists and antagonists and what they do with that particular receptor. I'll get into that in just a second. And as you can see on the right part of your screen, this is a very iconic image of what a neuron looks like. So let's zoom in further into that image, and maybe you've seen this one drawn out to you before. But generally speaking, when a neurotransmitter is released from the presynaptic neuron, this one right over here, and then goes over to the postsynaptic neuron, this one right over here to the right, when these neurotransmitters are released, these little circles from the presynaptic neuron, it binds itself to this receptor over on the postsynaptic neuron. But this system is really kind of complex because not all neurotransmitters, like I said, can bind to all receptors, and it works on kind of like a lock and key mechanism, meaning that not all neurotransmitters can bind to all receptors. And think about it like a lock. Not all locks can be unlocked by all keys. And so as you can see from this simple diagram, that the circle neurotransmitters can bind to the receptors, but the square ones cannot. So that's a very simplistic way of looking at this situation. We'll revisit this exact image in a little bit as well. And as we just now talked about, what we know is that agonists activate the opioid receptors fully. So thinking about that lock and key metaphor that I'm using, this is comparable to a key that fits into the lock. It's able to turn the lock and open that door all the way. So it has a full effect on that lock and key. Opens the lock, the key opens the lock, and the lock opens the door all the way. Pushing that metaphor forward is that partial agonists, they can fit into the lock and they can turn it and unlock it, but the door only will open halfway. And then just go a little bit further, as we know, we said antagonists are very similar to agonists in that they bind to the receptor, so that key is going to fit into the lock. But the difference is that the key is not going to turn the lock and it's not going to unlock it. But instead, it's simply going to sit in that lock and prevent any other keys from unlocking the door and activating that receptor. So I hope that that little analogy helps with thinking about the different ways in which the agonist, partial agonist, and antagonist affect the receptors. Again, we'll talk about this some more. So again, just getting some basic information laid down so we can build on top of it. There are 3 neurotransmitters that are relevant to our discussion for opioid consumption and dependence, the first one being dopamine, and it regulates motivation and pleasure. Dopamine is present through most addictive psychoactive chemicals, and it increases dopamine, including outside of psychoactive chemicals, such as when you're eating or gambling or having sex. Dopamine is also increased with all of these pleasurable activities, and that makes a lot of sense because if you're feeling pleasure, most likely it's coming from dopamine. Then we have opioids, and these are those naturally occurring opioids. You may also know them as endorphins within your system, and they're those naturally occurring pain reducers that increase naturally when one feels pain or experiences pleasure. So that's occurring here with opioid dependence. We'll talk about how. And then lastly, this might be a new one for you, but noradrenaline. It's also known as norepinephrine, and this contributes to the fight or flight response. And noradrenaline is mostly due to stimulating wakefulness and increasing breathing and increasing blood pressure and having alertness. So let's talk about this in a little different way as well. I know that these are very technical terms, scientific terms that we're using, so my brain doesn't really digest that kind of stuff as good as it should, and maybe some other participants out there feel the same way. I like to break this kind of stuff down to be as simplistic as possible. So let's look at what's on your screen here. Talking about those same 3 neurotransmitters, I've attached a couple of illustrations just to help trigger in the brain as we're talking about them what each of those neurotransmitters are designed to do. So there's a smiley face here for dopamine because it makes you happy. And then we have a very cheerful, gleeful, happy man clicking his heels. If you're in a live presentation with me, I'll actually try to attempt to do that and sometimes fall down. But either way, it makes you feel euphoric and you feel no pain. That's when we're talking about opioids. And then for noradrenaline, we have a coffee cup there because it makes you wake up. So let's push those forward and see what more we can learn about these 3 neurotransmitters. So the beautiful thing about research is that it has 100% identified and pinpointed these biological changes in the brain that's caused by excessive opioid consumption. And they've identified 2 main neuronal activities that take place in the brain simultaneously. And just to be clear, there are many others. But for the purposes of today, we just want to talk about these 2 main neuronal activities to help explain how opioid dependence sets in, what withdrawals look like, and how these medications can help. And so what I think is really beautiful about the research that's been done is that by pinpointing those neuronal activities, researchers have then had the opportunity to look at opioid dependence from a biological perspective and then develop the pharmacotherapies to aid in their treatment. So they go hand in hand. Once you understand what's occurring in the body to make opioid dependence set in, you can then work backwards and figure out ways to help reduce some of those symptoms or to reduce the dependence hold. And just to be super, super clear out there, the changes that I'm about to talk about in the brain, they're occurring whether a person is taking a medication that's prescribed for pain relief or whether there's a person out there injecting heroin on the streets. The body does not know the difference between a prescribed medication and an opioid. They're all agonists. Remember me saying that. All of them are working in the brain in the same way. So if you've got an agonist on board, the brain doesn't know that there's a prescription that comes along with that Percocet. So therefore, don't become addicted to it. The brain's going to respond to it the exact same way regardless if there's a prescription or not. So as we're going forward, don't tease out recreational use and heroin from someone who had a back injury who is now prescribed pain medication and has become addicted to it. It's happening in the exact same way in the brain. Let's talk about that. So starting off with our first neuronal activity, just thinking about just the first pathway right here. The first thing that obviously has to happen is opioids have to be ingested to trigger this cycle. The second thing is going to happen is naturally it's going to bind to those opioid receptors. And then here's something that's really interesting. What we know is that when opioids bind to opioid receptors, the next thing that happens is that the neurons that are located in a certain part of the brain, we'll just call it LC for short, are suppressed. and they're unable to release the noradrenaline to various parts of the brain. So you can see that little icon on the right-hand side where it has a big line drawn through the coffee image of a coffee cup, because that means noradrenaline is being suppressed, and so all of the activities necessary in order to maintain that wakefulness is being suppressed, and so the person is not as awake. So let's do a little quiz here, or a little polling question. So if noradrenaline is suppressed when opioids are consumed, what physiological effects would you expect an opioid user to experience? So just think about that. If someone's not able to have noradrenaline running at the same amount of frequency that it was before, what would be the side effects? Go ahead and submit an answer there. You can check multiple boxes or just one, your choice. Give you just a few seconds more. Okay, great. So you guys got it for the most part. And unfortunately, this is a trick question on my part. All of these things you're going to see. Naturally, you would imagine that if that coffee cup is taken away, which we know helps with wakefulness, you're going to see some results that look like drowsiness and some slowed breathing and a lowered blood pressure. And so all of these are descriptions of all of those symptoms that I was talking about at the very beginning that were in red for agonists, because these are the natural effects that happen when someone takes opioids. And I bet you've seen this client in front of you if they've been intoxicated during the time period that you've been around them. So that's the first neuronal activity. Let's put that one off to the side. We're going to keep revisiting it, but let's just put that to the side for the moment, and let's look at the second one. So again, starting at the main process is that opioids are ingested, and then we know the opioids bind to opioid receptors. And then this naturally causes an effect in and of its own. So again, when we have the opioids ingested and then they bind to those opioid receptors, the next thing that happens is that opioid stimulation activates two other areas in the brain called the VTA and the nucleus accumbens. And that causes a release in dopamine. So as you can see from those two little icons, we've got the jumping man clicking his heels because he's really euphoric. That's from the opioid. And then we've got that smiling face because he's really happy, and that's from the dopamine. And that makes sense because whenever you have witnessed anyone who has been intoxicated or has been under the influence of opioids, then they would naturally feel euphoric. They don't feel pain. They have a decrease of noradrenaline, so they have that nodding. These are all the effects that you would naturally want to see, and this is why it's happening. And so what we know about dopamine is that it's that main reward neurotransmitter. And so, of course, increases in the nucleus accumbens make this opioid user feel happier. That's why we have that smiling face there. If you've got dopamine and opioids on board, that individual is going to feel pretty good. And then, of course, the brain remembers those good feelings caused by the increases in dopamine activity. And then, of course, we're human. The brain wants to feel that good feeling over and over again. So, of course, it's going to have the desire to repeat that behavior again to get those same good feelings. And this is exactly where the cycle of opioid dependence begins or it ends, depending on the frequency of consumption. If that individual stops using opioids at this point, then the body will reverse itself and it feels natural without them and everything will be fine. If they continue to use them, then the body's going to start making adaptations because of the constant presence of opioids and constantly needing to feel good all the time. So let's see what that looks like. This is the exact moment that opioid dependence sets in, as I just now said. If they continue to use, the brain is going to figure out a way to adapt to that constant presence. And what we know about the brain is that it really carefully coordinates the activity of all of those neurons throughout the body. And it wants to maintain something called homeostasis, an equilibrium inside the brain. And so whenever the brain is exposed to external substances, such as opioids, for example, or really any outside drug at this point, including opioids, the brain is now overridden from natural functioning, and then that natural functioning is now altered. And so if a person doesn't chronically abuse these opioids, then the brain is able just to go back to normal levels of functioning and everything will be detoxified from the body and it will all go back to normal. But if a person repeatedly consumes opioids, then the brain is in a constant state of imbalance. And the brain will not tolerate being in a constant state of imbalance. And that balance, that equilibrium, again, that word is homeostasis. And so it's naturally always going to find a way to get back to homeostasis, even if that means it has to adapt itself to the constant presence of opioids. And that is exactly the moment that opioid dependence sets in, when those changes in the brain start to happen, because the brain is so used to having opioids on board, it's going to change itself so it can function normally when opioids are on board all the time. So let's see what that looks like. So as we've already talked about, we know that there is a suppression of noradrenaline. And so what the brain wants to do is that it's thinking, well, shoot, if I'm not getting enough noradrenaline out there and I'm not feeling awake as I should be, then I must just need more noradrenaline. And that's exactly what the brain does. It increases the level of activity of noradrenaline to regain that homeostasis. So now it has made a shift to where there is roughly normal amounts of noradrenaline that are flowing throughout the body with opioids on board, and that makes the opioid-dependent individual feel more or less like normal. Because let's think about that all the way through, is that if you've got opioids on board, which then suppresses noradrenaline, the brain is not feeling normal. And so therefore, it's now increased the amount of noradrenaline that's flowing through the brain, therefore making the individual feel normal, but only feeling normal when opioids are on board. That's the scary part. The brain is now so used to opioids always being there, it's adjusted itself so there's more noradrenaline to offset the constant presence of opioids. So now your brain functions normally with more levels of noradrenaline on board, but also with only having opioids on board as well. That's the scary part of opioid dependence. So let's do another little polling question here. What physiological effects would you expect to see from an opioid-dependent client who stops consuming opioids and now has an influx of noradrenaline? So put a different way, if there was an individual who has been consistently using opioids and the brain has adapted to having more noradrenaline, and then they stop using opioids, what do you think is going to happen when they have an influx of noradrenaline? Give you just a few more seconds on that. All right, you guys are completely correct. It's another trick question. You're going to see jitters and anxiety and muscle cramps and diarrhea. And any counselors out there that's ever seen a client who is going through opioid withdrawals, this is what it looks like, because they have so much noradrenaline running through them to try to offset the constant presence of opioids. If there isn't a constant presence of opioids anymore, but the brain is used to having that much noradrenaline pumped out to offset it, then of course you're going to have too much noradrenaline on board. And what do we know about noradrenaline? It's that coffee cup. It keeps you awake. And so therefore you're going to be overly awake. You're going to have jitters and anxiety and those muscle cramps. It's normally what happens with withdrawal. So another thing that we know that happens as opioid dependence sets in is that the more opioids that are exposed to the opioid receptors, the more desensitized that they get. They get used to that constant overactivity. And so that means that they sort of turn down the volume on how much activity they're going to produce based on the same amount of opioids they're usually getting. It's just a little too much, so they just turn the volume down. And so that means that the same amount of opioids no longer produces the same level of stimulation that that user is used to. And that's exactly what is called tolerance, because the brain itself is getting so used to the constant presence of opioids, it's not having the same effect anymore, so therefore tolerance sets in. And what do we know about tolerance? We know that if those opioid receptors are not as responsive to opioids as they used to be, then that means the VTA and the nucleus accumbens are not being activated at the same intensity. And so the VTA and the nucleus accumbens are not being activated. That means not as much dopamine is being released, which means there's not as much happy feelings happening. And that usually makes a very unhappy opioid user, because now that opioid user does not feel the same level of pleasure as they previously experienced. And what do you think they're going to do? They're going to try to take more opioids in order to achieve that same level of high that they were previously experiencing before tolerance. This is exactly where that phrase chasing the high comes in, because early opioid users have a much better high because their brain has not adapted to the presence of opioids and they haven't been oversensitized. And so therefore the high is much better. But as time goes on, the brain has a lot of overactivity, and they reduce the stimulation that's coming out of it. So therefore, they're not getting the same high, even if they're taking the same amount of opioids. And so they're constantly waiting to come back, no matter they keep having to increase the amount of drugs that they're taking to feel the same high they did before, and sadly, it's not going to happen because their brain has already become desensitized to it. So that's what opioid dependence looks like. And I think that that's really an interesting time to pause. And if we were in a live presentation together and I could see your faces, I think we would see a little bit of a shift happen at this point, because all of the things that you physically see in your clients have a biological reason in the brain that is manifesting. And now that we can understand what those manifestations are, there's ways to reverse those out and try to make the client feel better and tackle opioid dependence in a different way. In order to understand how those medications are going to come on board and be effective, we essentially have to understand opioid withdrawal, because that's where most of them work. It's the place where the opioid-dependent user is withdrawing. So as you know, whenever an opioid-dependent client stops consuming the opioid, then the brain is once again in an imbalance. And as I explained before, the brain is not going to stay in an imbalance. It's going to have to try to correct itself. But what we know is that it takes a while for all those adaptations that took place, such as increasing the amount of noradrenaline that's in the system. It takes a while for that to reverse itself and lower the amounts back down to normal amounts prior to when all this happened. And so what it's going to do now is that when opioids are not present, as we talked about in the previous question, then we've got neurons located in the LC that are free to behave normally. And so this causes a lot of noradrenaline to be released and distributed throughout the body, and that is increased pretty dramatically when opioids are processed out of the system and there's nothing balancing it out. And so this causes withdrawal symptoms. And we know that withdrawal symptoms are basically just the resurfacing of the functions that have been suppressed or altered by opioid consumption. That's why it's important, that question I asked you of what do you think is going to happen if we stop taking opioids at this point, but we have a whole influx of noradrenaline? Well, you're going to see those jitters and the anxiety and the muscle cramps and the diarrhea, for example. That's the reversing of the suppression of noradrenaline that was happening before. And we also know that the intensity of opioid withdrawal symptoms depend directly on the type of opioid that's being consumed and the amount and the frequency at which it's being consumed, as well as the duration of the abuse. That will let us know how effective those opioid receptors have been and how much ground we have to cover. And one other important point here is that even though opioid-dependent individuals who are withdrawing from opioids feel like that they're going to die or they wish that they were, this is not actually life-threatening. They just feel that they want to. So for individuals who are otherwise generally healthy, that opioid withdrawal symptoms should just be uncomfortable and not life-threatening. And we also know that the withdrawal symptoms are experienced in two phases. We'll talk about each of these independently, but the first one is the acute opioid withdrawal symptoms, which happen right after the individual has processed out half of the opioids from their system, also known as half-life. And then there's the protracted opioid withdrawal symptoms, which occur many days after. We'll talk about that in a second. So starting first with acute opioid withdrawal symptoms, you can see what those symptoms are on your screen. It's many of the ones that in my trick question I asked you a few minutes before. You can see those listed here, as well as some other ones. I'm sure that they seem very recognizable based on the clients that you've witnessed. And as I said before, these are just the opposite of the acute intoxication symptoms. They're just the opposite of what someone feels if they are intoxicated by an opioid. When they're withdrawing from it, they're getting the opposite effect. And we know that these symptoms are going to start occurring. The acute opioid withdrawal symptoms are going to start occurring dependent upon the length of time that the client has been taking the medication, or I'm sorry, been taking the drug. And that is directly dependent on the half-life of the opioid that was last consumed. And this is very different depending on the drug that's being consumed. But we know that most opioid dependents try to consume their next dose of an opioid when half of the last dose has been removed from the body. That's when they start to feel what's called quote-unquote sick. When those withdrawal symptoms start coming up, that's usually at the point of half-life. So half of the drug has been processed through the body, and there's not enough left in the system that creates the same effects, the desired effects that the individual wanted, and so now they're starting to feel the reverse effects, and that usually happens when half of the last dose has been removed from the body. And so this is exactly the moment when you would think of perhaps a heroin user, for example, that if the brain is really accustomed to the constant presence of opioids, you're going to need more opioids right at that half-life point to avoid those withdrawal symptoms. And I'm sure that you know lots of individuals who have a pattern of use that looks just like that. They have to get up first thing in the morning and have that first dose in order to stop being quote-unquote sick, because they're in withdrawals because they haven't had any dose while they've been asleep. And so when they wake up, they're in opioid withdrawals, and so they want to try to fix that. They do their first dose. Then a little while later, when that has halfway removed from the body, that's the exact moment they're starting to feel sick again. They got to get another dose. So here is a visual representation of what I was just talking about, is that in the morning, you start to feel sick, you get a dose, you're high, then you start to come down, you get another dose, you go back up to high, you come down, you keep going in this whole process here. And then for individuals who are deep into opioid dependence, they're going to stay only at sick, and then when they take their first dose in the morning time, that's only going to put them up to this straight category, meaning they're going to relatively feel normal. They're no longer going to be getting in that high category because their receptors are desensitized at this point, and they have been a dependent user for a long time, and so they're just not going to get up to that plateau. They're going to stay from being sick to straight, and no longer feeling the euphoria coming from the opioids any longer. So as you can probably imagine, this process, especially this person over here on this side that is only getting the effects of not being sick and no longer getting the effects of feeling euphoric and feeling really good and doing the drugs for the reason they started out with, is that it felt great. They're now only doing it to prevent themselves from feeling sick, which is preventing those withdrawal symptoms. So that's when medication-assisted treatment comes into play a whole lot, because a lot of opioid users are not willing to go through the withdrawal symptoms in order to stop being dependent on opioids. And so this is a moment in time where they have to make a decision of how they're going to go in the treatment, and where you can start talking about certain options to at least get them out of the drug trade. And some people call it harm reduction. Some people call it chickening out. So it's just a way that you view medication-assisted treatment, but in a sense, it's what it's doing. It's preventing withdrawals. So we're going to talk about that some more when we go into the medication. So that was acute opioid withdrawal symptoms. This is the protracted opioid withdrawal symptom phase. And we know that this is generally less severe than the acute withdrawal symptom phase, but it still can be super uncomfortable. And we know that regardless of the length of time that these acute withdrawal symptoms persist, the protracted withdrawal symptoms are going to occur for about a couple of weeks to months after the last opioid is consumed. So an individual is going to, depending on that opioid that they've been dependent upon and how long their half-life is and the duration of action, will dictate when those acute opioid withdrawal symptoms will come into play. But then as soon as those are over, for sure they're going to have a protracted opioid withdrawal symptom phase that's going to last for a couple of weeks or months. So that's withdrawal. So taking all that information in, I'm going to start applying it directly to the medications that have been FDA approved in order to treat opioid dependence. So there are currently 4 FDA-approved medication-assisted treatments for opioid dependence. The first one came on the scene in 1964. I'm sure you're familiar with it, Methadone. Then the next one came along 20 years later, and it works in a very different way, Naltrexone. As you may remember, Methadone is an agonist. So Methadone works like heroin does. It works like OxyContin does. It is an agonist and has full effects on the brain and the body. Naltrexone is an antagonist. If you remember, Naltrexone and naloxone, also known as Narcan, are those that the key fits into the lock, but it doesn't turn it, it doesn't open the door, it just sits there and blocks any other thing that wants to come and sit on that receptor. So Naltrexone works very different than Methadone. So it wasn't a replacement for Methadone, it's a different version, it's a different approach to treating opioid dependence. Then in 1993, LAM came on the scene, but we're not going to be talking about LAM today because discoveries in research found that it was pretty unsafe and have led it to be discontinued in the United States, so we're not going to be talking about it today. But it is still officially approved by the FDA for medication-assisted treatment for opioid dependence. And then the last one came on the scene in 2002, which is Buprenorphine. And so you can see that we've gone about 20 years' time between each of these medications, and they approach things very differently. And so there are 3 different options for 3 different types of clients and for 3 different types of opioid dependence and how you want to approach it. So I want to dive directly into this now. Starting first with Naltrexone. You can see some images of what that medication looks like. The generic name is Naltrexone hydrochloride. It's marketed as Revia or Depaide. And its purpose that is printed on that small little medication package insert with a teeny tiny little print. I'm reading directly off of that so you can know where to find this information. But the purpose is to discourage opioid use by reducing or eliminating the euphoric effects experienced by consuming externally administered opioids. We'll talk about what that means. And its indication is in the treatment of alcohol dependence. That's for a different presentation, and for the blockade of effects of externally administered opioids. So this medication is FDA approved for both alcohol dependence and opioid dependence, but because it works in the brain in the same way. If it activates opioid receptors, which it does for alcohol dependence and for opioid dependence, it's going to block all of that release of dopamine that comes after. I'm kind of giving away the cart before the horse here, but that's a little teaser of what's about to happen. So as I said, it was released in 1984, and it is an antagonist. The prescribed medication is one 50-milligram tablet taken by mouth once a day, and it can be crushed or diluted or halved or mixed with food. The whole key is that you must be abstinent from opioids for at least 7 to 10 days prior to treatment initiation, and there's a reason for that, is that if there's opioids on board at the time of taking Naltrexone, just like taking Narcan, it's going to kick off all of the opioids in the body right there on the receptors, causing that individual to go to immediate opioid withdrawal. And so for this medication to be most effective, you want to take it 7 to 10 days after the last opioids have been ingested. That way there are no opioids on the receptors to be kicked off, so no withdrawal symptoms will follow. It will just prevent any additional activation of the receptors after the medication's been taken. We'll talk about that a little bit more if you didn't catch it then. There is no difference between the starting maintenance and ending dosages, so there's no tapering up or tapering down. And there is a small risk of overdose, but they have done testing up to 800 milligrams daily, which, as you can see, is 19 times the amount of daily medication that should be taken, and no serious side effects were noticed at that point. Although you should note if there is a bit of an overdose, just contact the appropriate medical treatment so it can be sought. So Naltrexone itself is not addictive in any capacity. It does not have a high abuse liability, and it does not cause the development of tolerance, or it does not produce withdrawal symptoms when the medication is ceased. It doesn't produce any euphoria. It doesn't produce anything at all. Remember on that diagram that I showed you of a line going all the way up to death, that's agonist, and then a partial line going in the middle, that's a partial agonist. But Naltrexone is an antagonist. It was that line going all the way down the bottom. It activates those receptors. It sits on those receptors, but it doesn't activate it. So nothing happens with Naltrexone. It's just blocking it. And so there's also been no reports of injection or smoking or prescription deviation at all for this medication. And what that means is it's not being sold on the street. Nobody's out there crushing this up and injecting it into their arm. But if they did, it's important to note if they have opioids on board and had heard that this medication could be a nice replacement for methadone or something like that, and they were expecting a high and they did try to put it in their arm, for example, or just take the medication, they will evoke opioid withdrawal symptoms in clients. Absolutely. And then there's third-party payer acceptance. It's covered by most major insurance carriers, including Medicare, Medicaid, and it is prescribed by the VA. So this is a medication that's widely available out there and covered by insurance. So let's talk about how it actually works in the brain. I've given you a little teaser, but let's go in deeper. So just to trigger your memory, just to remind you, there is an increase in opioid stimulation in both the nucleus accumbens and the VTA. And because there's a stimulation in those two parts of the brain, dopamine is released. And remember, dopamine in these areas makes the body feel good, and that user remembers it. And so how Naltrexone works is that it's an opioid receptor antagonist, and so it blocks the opioid receptors where opioids are consumed. So at first, it sits on that receptor and blocks all activity. And then second, if any other drugs are taken, it doesn't allow them to activate, and so therefore it diminishes that reward of taking that opioid, and the acute reinforcing effects from the dopamine are not felt, so they don't really feel anything. It just doesn't allow it to sit on that receptor. So they can have naltrexone on board and then take a little heroin. It's not going to work at all. So that's how naltrexone works. So moving on to methadone, it works in a very different way. So methadone is called methadone hydrochloride. It's marketed as methadose or Dolphine. It's got lots of other names as well because it's in generic form at this point. So those are just two of the main ones. It can be taken in pill form. It's also in a liquid. There's lots of different ways to take methadone. And its purpose is to discourage illicit opioid use due to the cravings or the desire to alleviate opioid withdrawal symptoms. So what does that tell you? Broken down into clear language, that's saying that if you are afraid you're going to go into opioid withdrawal and you don't want to do heroin anymore, but you don't want to have opioid symptoms, then you can have methadone as a replacement. So it literally is exchanging an illicit drug on the street for methadone within a clinic being monitored by a prescription. And so this is not a medication that is going to affect the body any differently than in other agonists out there. It's going to produce euphoria. It's going to produce a high. It's going to stave off withdrawal symptoms, just like any other agonist would. So if you've got a person sitting there saying, shoot, I really want to stop doing heroin, but man, I just cannot handle being sick all the time. I cannot go through it. Every time I only get like 2 or 3 hours into the withdrawal symptoms, and it's just hell, and I'm not going to do it. But I don't want to do heroin anymore. Methadone is a great alternative that just allows that individual to stave off those withdrawal symptoms and be taken off the streets and get out of the drug trade. Obviously, there's a whole lot of controversy about methadone because, as I said, it will get you high. You can sell this on the street, and many, many, many people do. And so there's been a search out there to try to find a medication that can replace methadone that doesn't have the same diverting effects and doesn't have the same euphoric effects. And just as a little teaser, that's where buprenorphine comes in. So let's continue on with methadone. The indication for methadone is for the treatment of moderate to severe pain, so it is a pain reliever that's non-responsive to non-narcotic analgesics. And then it's also for the detoxification treatment of opioid addiction and for the maintenance treatment of opioid addiction in conjunction with appropriate social and medical services. Again, this information is coming directly from that medication package insert. So this is what the FDA is dictating in their exact language. It must be in conjunction with appropriate social and medical services. So anyone out there that is getting some pills or a dosage of methadone on the street or from someone who is not a prescriber, then they're getting it illegally in a way that is not being monitored by medical professionals as it was intended. The maintenance dose of methadone is between 80 to 120 milligrams, taken by mouth once a day. The effect of consuming food with methadone hasn't been evaluated, so they don't recommend it. That's not to say that it does have an effect, but they just don't know. And this is a medication that was hit the scene in 1964, and that's not something that was actually researched back then, so they haven't gone back to look at that yet. And for the abstinence requirements, you just want to be abstinent enough so the opioids are causing some opioid withdrawal symptoms. You want to have mild to moderate opioid withdrawal symptoms, and that makes sense because the whole purpose of this medication is to stave off withdrawal symptoms. So you don't want to take it when you're feeling high. You don't want to take it whenever you are feeling when you still have other opioids in your body. You want to start taking this to make it so you don't go into that sick category, which is what you're trying to avoid by taking heroin to begin with. The initial dose varies depending on the client's pattern, and so it shouldn't exceed 40 milligrams to start right off, but during the initial dose and moving into the maintenance dosages, you're trying to figure out what is the best dose to, again, just be right at that point of staving off withdrawal symptoms with causing the least amount of euphoria possible. And that risk of overdose is very real, just like with any opioid agonist. I can't emphasize this enough, and that is what methadone is. Overdose is possible. You can take enough heroin to kill yourself. You can absolutely take enough methadone to kill yourself. There is nothing blocking the body from thinking this is any other opioid just because it's being used as a medication. The brain is taking it as an opioid agonist, which means that the effects on the receptors will continue based on the dosage. If enough methadone is taken, the effects will continue to rise, and then that person will be in respiratory depression and most likely overdose and die. For pregnancy, methadone is actually the recommended medication of all the three that we're talking about today. And the reason why is they haven't been able to do enough research for buprenorphine yet to override that recommendation for methadone. But all of these medications are called pregnancy category C designation. And what that means is that it should be used during pregnancy only if the potential benefits justify the potential risk to the fetus. And so what this means is that babies born to mothers who have been taking opioids regularly prior to delivery may be physically dependent and may experience opioid withdrawal symptoms. Again, I can't emphasize this enough. If a mother is taking heroin while she is pregnant, that baby is most likely going to be physically dependent and addicted to opioids when it is born. And when it is removed from its mother and no longer have access to that opioids running through the bloodstream, that baby will go through opioid withdrawal symptoms. Same thing is true for methadone. I don't want to mislead you about that. You can see the potential benefits to the birth mother and to the baby if that mother is not on the streets injecting heroin or is not taking 50 OxyContin a day, for example. There's a benefit if she's being monitored by medical professionals and dosaging is being set based on just to get those withdrawal symptoms staved off and not produce euphoria as much as possible. And that means that the baby's going to be exposed to a lot less additives, a lot less, unsterile environments and needles and all the other things that come along that are very dangerous for being in the illicit drug trade. And so it could be beneficial in this particular situation to take a patient, a mother who is pregnant, off of an opioid on the street and put them onto methadone so they're being monitored. But again, that baby is still ingesting through the mother's bloodstream an opioid agonist, which means that it does have physical dependence, and that baby also still will be physically dependent to opioids most likely and experience those opioid withdrawal symptoms that come after. But again, this is the preferred method of treatment for medication-assisted treatment for opioid dependence in pregnant women, and they are looking at other ways to evaluate buprenorphine to see if that might be a better replacement. As I said before, chronic administration produces physical dependence when we're talking about methadone. Methadone is an opioid. It does have a high abuse liability, and it does produce withdrawal symptoms when the medication is ceased too abruptly or tapered down too quickly. The whole thing is that your body is constantly addicted to the presence of opioids. When you replace one opioid with another opioid, it's still addicted. That hasn't changed. The goal is to make it so it's less addicted over time by tapering down that medication, methadone or buprenorphine otherwise, tapering it down so the brain is constantly readjusting the amount of opioids that it's used to, slowly but surely getting down to little or nothing in time. That's the goal. And so third-party payer acceptance is covered by most major insurance carriers and Medicaid and Medicare, and it's prescribed by the VA, so it is widely available out there. So that's methadone. Let's see what we know about buprenorphine. So here's some images of what buprenorphine looks like. Its generic name is buprenorphine hydrochloride. It's marketed as Subutex and Suboxone. Those are different medications. We'll talk about the differences between the two, and please don't confuse the two. They're very different, but both of them contain buprenorphine. So the purpose of buprenorphine is to discourage illicit opioid use due to the cravings or the desire to alleviate opioid withdrawal symptoms. That should sound familiar. That's the exact same purpose that methadone has. And the indication is for the treatment of opioid dependence. The abstinence requirements for buprenorphine are a little different, is that we need them to be abstinent from opioids long enough to experience the mild to moderate opioid withdrawal symptoms. That's the same thing as methadone. But this period of abstinence will vary depending on the previous opioids used and the level of dependency. Most of the single dosages that are administered are between 4 to 24 milligrams per day. But unlike methadone, this pill is administered sublingually. And what that means is it's underneath the tongue. They're not swallowing it. They're not chewing it up. They're not in any way dissolving it. It's just going under the tongue to then be dissolved and absorbed by the mucous membranes under the tongue. And if they swallow the tablets, that reduces the effect of it, also called bioavailability of the medication. So it should not be swallowed. It will not have the same effect. It has to be dissolved underneath the tongue. And at the same time, don't take it with any food or crush it or half it or dilute it in liquid in any way. It has to be absorbed through the mucous membranes underneath the tongue. And for buprenorphine and for methadone as well, there are 4 phases associated with the medication-assisted treatment for opioid dependence. The first one is induction. That's just what it says. You're introducing the medication, trying to figure out what the best dose is. Stabilizations, when you're playing around with the dosage to try to figure out what is the exact right mixture and how many milligrams an individual needs to just put them right over that line of having withdrawal symptoms. We want to make it so they have no withdrawal symptoms but have the least amount of euphoria and psychoactive effects as possible. Then that third stage is the maintenance. Once you find the dosage that works for them to stave off those withdrawal symptoms and let them function normally, then they're in maintenance stage, and that just continues on for as long as the patient and prescriber agree to. And then the final stage, which honestly is sometimes optional for some of these clients, and I'm not proclaiming one way or another, I'm just stating that there is a fourth phase that someone can utilize, but some choose not to. Some may stay on methadone or buprenorphine forever, but some need to be medically assisted withdrawn from the medication. And what that means is it'll be tapered down slowly but surely in small dosages to, again, stave off those withdrawal symptoms and keep the euphoria down, but also try to reduce the effects and the adaptations the brain has occurred over the past several years of drug dependence. As I explained before with methadone, buprenorphine also has a pregnancy category C designation, but we strongly recommend that methadone be used in this instance. But there are clinical trials that are underway right now. Just like with methadone, chronic administration of buprenorphine does produce physical dependence. It does have a high abuse liability. It does produce withdrawal symptoms when the medication is ceased abruptly or tapered down too quickly. It is a partial agonist. That means in low doses it works just like the other agonists do, which methadone is, and in higher doses it works a little differently. And I'm going to introduce this right now, but we'll talk about it more in depth in a moment, is that due to that potential for abuse that was discovered with methadone, Suboxone was created with another drug inside of it, or another medication called Naltrexone, which we've been talking about, Narcan. And so that prevents it from being enjoyable when it's intravenously injected. And by having Naltrexone on board with Suboxone, that mechanism drastically reduces its abuse potential and the street value in comparison to Subutex. And I know I'm just introducing this, but I wanted to start off saying that it does have some addictive properties, but there's some built-in components to make it safer. And this medication is accepted by major insurance carriers, and at the time that I made this presentation, the only state that did not accept it for Medicaid was Louisiana, and it is being accepted by the VA and prescribed. So let's talk about how buprenorphine works. This is a really, really fascinating medication. I hope I do it justice. Is that, like I said, it's a partial opioid receptor agonist, which means that both agonist and antagonist characteristics are present in this buprenorphine. And so at low doses, it binds to and activates those opioid receptors just like other opioid receptor agonists. And then at higher doses, the agonist effects of buprenorphine level out. And so the psychoactive effects of the full opioid agonist continue to increase as the dosage increases, but that's not what happens with buprenorphine. It's just ceiling effects, and it's that middle line, if I can trigger that image in your head. It's the middle line to where it does not continue to increase effects as the dosage increases like other agonists. And so buprenorphine works in two really important ways. The first one is it prevents the opioid withdrawal symptoms by providing mild agonist effects, and that's what the individual is after. If they were willing to go through withdrawal and stop heroin or OxyContin use right from the very beginning, then this medication wouldn't be necessary because they're going to go through withdrawals. This is for the individual who does not want to go through withdrawals and refuses to stop their illicit drug use if they have to go through withdrawals. And so that's the first effect. It stops those withdrawals so you're not going to feel them, but you're not having to purchase any illicit drugs on the street. Secondly, then it occupies the opioid receptors, so illicit opioids will have no effect. This is where it works a whole lot like Naltrexone, is that once it gets onto the receptors, you can see them flashing there, those little beads. It's giving enough of an effect to make the body be tricked to think that it's actually got some opioids on board, which it does, but just at low doses. And so that pushes off the withdrawal symptoms. But then, if that individual wants to then go take heroin and they change their mind, they're like, forget it, I don't care about this buprenorphine, I'm going to just go get high, that buprenorphine is holding so strong to that receptor, it is not going to allow any heroin or any agonist, for that matter, to in any way affect those receptors. So they will not get high. They can inject themselves. They've got buprenorphine on board. They're not going to get high. They're going to inject themselves another dose thinking, shoot, let me see if I can get high. They're not going to get high. But a caveat, I don't know the exact point at which it crosses over, but they can override buprenorphine at very, very, very high doses. And if they do that, if they're that determined and they override buprenorphine, there's an extremely good chance that they're going to be in the overdose category of where they have too much agonist on board, and that's going to put them in overdose and most likely have respiratory depression and most likely death. So that's the scary part about it, but they've got to get to really high doses, and we're hoping that after trying 1 or 2 times of trying to override it and failing, that they'll give up. But that is a potential consequence of this medication, as with all agonists, partial or otherwise. So think about buprenorphine as like the schoolyard bully. So if you've got a client who's recently consumed some opioids, such as heroin, for example, when a high dose of buprenorphine is taken, that heroin that is bonded to the opioid receptors is just kicked off. So it just got completely kicked off. That schoolyard bully just completely replaces it with buprenorphine. And then if the opioid-dependent client consumes opioids while buprenorphine is in the system, the opioid receptors are not going to be activated because they're already occupied. And so that dependent will not experience any of those desired effects. And so the beauty about buprenorphine is that it does have a short half-life, but it has a really long duration of action. And what that means is that it is binding really strongly to that receptor, and that's called receptor affinity, meaning that it holds really strong onto the receptor. Nothing can knock it off, and it's going to stay on there for a while. And what we know based on research is it's going to stay on that receptor undisturbed up to 24 to 72 hours, so 1 to 3 days. 1 single dose of buprenorphine will stay on that receptor and, 1, stop withdrawal symptoms, and 2, prevent any other opioid agonist that's coming on board for them to try to get high. It's preventing that effect, and so they're not going to be able to get high. And so it also has this really great safety profile that I think is so interesting and really ingenious to come up with, is that the first reason, as I've explained in depth, is that it's safe, is that it has that ceiling effect. You can take a lot of buprenorphine, and it's not going to keep increasing all the effects that put someone into that dangerous, life-threatening respiratory suppression phase. And so most likely they're not going to overdose on this medication. So that's a really good thing. And then secondly, buprenorphine has been put into 2 different preparations. Buprenorphine is the medication itself, the actual ingredient that is working, but the marketing name of 2 different medications, one is Subutex and one is Suboxone. Subutex just contains pure buprenorphine. That's all that's in it. Subutex is buprenorphine. But Suboxone contains both buprenorphine and naloxone. Remember, naloxone is Narcan, and that is an antagonist, so it has both of them on board. So Suboxone is the preferred method of buprenorphine treatment because it deters clients from using the medication inappropriately or selling it illicitly. So let's talk about what that means and why that would be true. We know that naloxone is an opioid receptor antagonist, and so if naloxone gets triggered in the Suboxone medication, then it's going to kick off all of those opioids that are on the receptors and cause that individual to go into full-blown opioid withdrawal. So that's the great part about it, is that if you take Suboxone, which includes both buprenorphine and naloxone, I'm getting confused with my words a little bit, bear with me. So if you take Suboxone that contains buprenorphine and naloxone, you take it as prescribed and you put it under your tongue, the naloxone is absorbed with 0 effect whatsoever, and the buprenorphine is absorbed like normally, and everything works perfectly. If that individual decides they want to take Suboxone and crush it up and inject it in their arm, the only thing that's going to have an effect on them is the naloxone. Naloxone is going to act as an antagonist, and it's going to kick off every single opioid on that receptor and cause full-blown opioid withdrawal. So that is the piece that makes this medication so magical, is that no one's selling this on the street, because if they do, then and they try to inject it into their arm, naloxone is going to come on board instead of buprenorphine. And then if they just sell it on the street and they put it under their tongue and they take it like they should, they're going to get a small dose of euphoria and a small dose of the buprenorphine to make it so withdrawal symptoms are staved off, but they're not going to get the same high they were looking for. So this is a much safer medication to have out on the streets than methadone. So these are the side effects of buprenorphine themselves. These occurred in 5% or more of the clients during clinical trials, so you can see that there are some effects, but with all medication, if you've watched TV in the past decade, you can hear the commercial goes on for 5 seconds, and then for 45 seconds they're telling us all the different ways that we're going to be affected and possibly die from taking medication. So here is that same little caveat for buprenorphine. Buprenorphine should not be administered to clients who have previously shown some hypersensitivity to buprenorphine or any of the components within the medication. And then obviously Suboxone should not be administered to those who have shown hypersensitivity to Naltrexone. Obviously, if you've been allergic to the medication in the past, you're going to be allergic to it again. They should not be taking that medication. And then further, if you're taking any opioid analgesics or actively using opioids, then this medication is not going to be for you. You're not in that withdrawal phase, so therefore the medication is not going to work as intended. It is not contraindicated for liver impairment. It's not contraindicated for kidney impairment. And it's not contraindicated for elderly or debilitated clients, but it should be used with extreme caution whenever this is prescribed to those populations. So here's a little comparison chart between naltrexone, methadone, buprenorphine to cover some of the big items here. So across the board, missed dose instructions, just take the missed dose if it's not almost time for the next dose. Otherwise, just skip that missed dose and resume the regular schedule. You don't want to double up. That's a no-no for all of them across the board, especially methadone. You take 2 doses of methadone, you're basically taking 2 doses of an opioid agonist. You're going to feel twice as euphoric and as pain relief. Same thing is not true so much for buprenorphine. It's going to go up to that ceiling effect and then level off. For naltrexone, there's not really an effect that you will get doubled up by taking 2 doses, but you don't want to overdose on the medication at all, which, again, 2 doses is nowhere close to that overdose amount that they've researched. But either way, standard practice, just take the next dose if it's not already time for the next dose, and then otherwise just skip it. The recommended length of treatment is 100% based off of the clinical trials that were conducted for each medication. So, for example, naltrexone, they just had 12-week trials, so that's as long as the FDA says that they clear it to be prescribed. That doesn't mean that it can't be taken for longer than 12 weeks. It just means it's called off-label use. And so, again, it's only based on research that they've done. And they haven't done enough research for methadone or buprenorphine. They just say they don't limit the amount of time for treatment for either of those medications. All 3 of them should be used in conjunction with comprehensive biopsychosocial spiritual treatment. The full program should be surrounded by these, and no one should ever be taking one or more of these medications without being in some other program that's supporting them. This is not a magic bullet, so it should be used alone. And for adolescents, none of the medications have been approved by the FDA for use with this population. Same thing for elderly and same thing for polysubstance abusers. Again, that doesn't mean that they can't be used with these age groups or populations. It just simply means that the research hasn't been conducted, and so therefore the FDA is not going to say that it's safe. And I bet you can imagine why there hasn't been research done on adolescents or elderly, is because adolescents have a hard time getting approval for research like this, and then elderly as well. They might have additional complications that you're not able to tease out in research to know what those exact effects of the medication are versus just other things that the elderly population might experience. Thus, that is why the age ranges for each of these medications are from 18 to 65, and then for buprenorphine it's 16 to 65. Again, the reason is 100% based off of the clinical trials that were done, and we know that it has been, quote-unquote, proven safe for these age groups. So let's do a little review here. Let's test some of our knowledge with the last minutes that we have together. So Scott's heroin addiction began in high school when he was first introduced to IV use by a friend of his. Since that time, he's been in and out of jail, treatment, methadone clinics, and numerous other types of residential and outpatient programs. He's been successfully treated with methadone for the past 6 months, but occasionally misses a dose due to the inconvenient dosing schedule. He currently is employed, likes his job, and has a girlfriend. She is supportive of his efforts to change his life and even attends some treatment sessions with him. So let's do a polling question on this to get your feedback of, do you feel Scott is a good candidate for medication-assisted treatment? And if so, which medications do you feel are best? Go ahead and just take a quick second on that. Okay, great. Let's see what the results say. So we got a mixed opinion about this, and I personally would say this is a great time to pause and say there's no right or wrong answer there. For each of these medications, they have some appropriate uses for various clients. So let me just talk you through a little bit of my thinking on Scott here. Is that it seems like he's got a really good support system. So he's got a girlfriend that's attending some sessions with him. He's been successfully taking methadone, which is an opioid agonist. So he is not in withdrawal symptoms at this time period. So Naltrexone, if he did want to move to Naltrexone, he would need to stop methadone for a period of time and make it so he would be eligible to do Naltrexone. So that might be my last choice if he's successfully moving along with methadone. Of course, at any point, he could switch from methadone over to buprenorphine if he felt that the inconvenient dosing schedule was enough to want him to do that. But by and large, he seems to be doing pretty well on methadone, and we wouldn't want to rock that boat unless he wanted to, in which case, then obviously there is a safer choice for buprenorphine to be used as opposed to methadone. But if he's doing fine on it, then there's no reason to change him out unless that's something he's wanting. So that's just a couple of thoughts that I have. Let's try another one. Lisa began using Lorset after dental surgery for the removal of her 4 wisdom teeth. She got an infection, and the dentist prescribed the painkiller for her. She was uncomfortable at first using a powerful medication to control the pain, but quickly changed her mind when she discovered its effectiveness. She's now uncomfortable with her regular and sometimes excessive use and wishes to stop completely. As a result, she called her psychiatrist for help and is now seeking treatment through him. She has not used any opioids in the past 2 weeks. Let's get your opinion on that one. Do you feel Talisa is a good candidate for medication-assisted treatment? And if so, which medication do you feel is best? Give you just a couple more seconds on that. Okay, great. These results are really helpful. I would have to agree with you guys on this one, mostly that she's probably not the best candidate for medication-assisted treatment, with the exception of possibly Naltrexone, because Naltrexone is not going to give her any additional effects. You can see that she has stopped using opioids for the past 2 weeks, so she has gotten through that acute withdrawal symptom period that most likely buprenorphine or methadone would counterbalance. So I would see no reason to put her on buprenorphine or methadone, because that would reintroduce opioids into her system when she's already cleared her system for the past 2 weeks of them. So I would say she's not appropriate for medication-assisted treatment, and if she did want a little extra security on board, then Naltrexone would be a really great candidate for her, because it's not going to produce any effects whatsoever. And if she did have a slip while she was taking Naltrexone and did take one of her pain medications, then it wouldn't have an effect on her body, so it wouldn't feel euphoric, and she wouldn't continue that use most likely. So that's my take on Talisa. Let's see about Lynette. Lynette graduated at the top of her class in college and has been a successful professor of English for the past 25 years at a local community college. After the birth of her last child, she experienced some mild to moderate back problems that have exacerbated over the past 20 years. She's tried a variety of treatment regimens, including holistic and herbal medicine practice, but to no avail. Recently, while walking, she injured her ankle and was last seen in the ER, where she was prescribed Percocet for the pain.
Hi, Misty. Sorry to interrupt real quick. We need to change the slide.
Oh, thank you. Okay, I'm hoping you can see it now. Is that Lynette has, let me get back to where we were.
The slide hasn't changed yet.
Okay, thank you. I'll
You're
continue
welcome.
to read it. Hopefully the slide will catch back up. Long after her ankle is healed, Lynette still continues to take Percocet every day, even though her physician recommends only taking it on bad days. This has gone on for over 2 years now, and she finds herself becoming more and more reliant on the medication. She is frustrated by her inability to just quit without experiencing the withdrawal symptoms and discomfort from not using the pain medication. Lynette is ambivalent about quitting and entering treatment for fear of being discovered as a user locally in her small community. So let's see what you think about Lynette. Do you think Lynette is a good candidate for medication-assisted treatment? Give me just a few more seconds. Okay, good. So we got some mixed reviews on here. Let's think about this. So Lynette is currently still taking medication. She is abusing her medication. And so most likely she is not going to be a good candidate for methadone, because I would say that that would be the highest abuse rate she could have. I think she would be a good candidate for buprenorphine if that's something she's willing to take. And also if she's willing to completely stop the opioids and jump off that cliff and make it so she has some more insurance on board, then naltrexone would be a great medication for her. I could also see her not being appropriate for medication-assisted treatment in that she doesn't seem committed to wanting to stop. So therefore, there might be some other interventions that need to come first before this becomes an option. Those are just some of my thoughts. And then finally, Sarah's been addicted to heroin since freshman year of college. After experiencing a near-fatal overdose, she completed an inpatient treatment program and is being maintained on methadone. She has tried to gradually reduce her methadone dose in an effort to eventually discontinue use. However, each time the dose is reduced, her cravings and desire to use increase. She has recently began abusing her take-home doses of methadone and supplementing her high with her mother's prescription of Percocet. So let's see what you think about Sarah. Do you feel like she is a good candidate for medication-assisted treatment? And which medication do you feel is best? Just a couple more seconds on that. Okay, well, I would have to tend to agree with the audience. I think that she is a strong candidate for buprenorphine use, or for buprenorphine medication-assisted treatment. Because she has been on methadone and is used to that dosing schedule, and she has had some success with it, she seems to be slipping off a little bit. And so how I think buprenorphine would be most helpful is that it would continue to maintain her not having withdrawal symptoms, the same way that methadone was attempting to unsuccessfully. But then she wouldn't be able to go home and take additional doses of the buprenorphine to increase that high. And even more so, she wouldn't be able to supplement her high with Percocet, because that buprenorphine would be blocking those receptors and only letting buprenorphine attach. So I think this would be a much safer choice for someone like Sarah. Obviously, she's going to need some continued treatment, continued psychosocial therapy in order to discuss all the things that are coming into play with the dependence. But talking just specifically about the withdrawals and the medication to help with that, I think buprenorphine is her best option. All right, so let's move on to the last portion of our time together here, and that's just talking about how to counsel the clients with medication-assisted treatment. So as you can see from the diagram on your screen, opioid dependence has 4 equally important facets, but often special attention is just given to one or more of the areas, but very rarely all of them. And if you buy into this chair concept, you got to think about that there are 4 legs to a chair that are required to quote-unquote support the client. And if one of those legs is missing, the chair will be unstable and unable to accomplish its goal of supporting the client who's sitting in it. And the biological component here, that leg, is enormously important to complement all the work that's being done in the psychological arena, all the friendships and the fellowship that's occurring in the social arena, and all the work being done on the spiritual arena need to have the support of all the real biological changes that are occurring in the brain. And to ignore that leg of the chair is to ignore one leg of the addiction and then one leg of the treatment that is available to that individual to have holistic recovery. So I strongly encourage you to keep this chair in the back of your mind, whether you're against medication-assisted treatment for opioid dependence or you're for it or you have mixed emotions. Please don't discount the fact that there are real changes that really have affected the course of this dependence that should not be ignored for its treatment. And as you can see from this diagram from NIDA, medication-assisted pharmacotherapy right here is one of the main ways in which we provide services and comprehensive effective treatment to an individual client. It is not the only one. It is definitely supported by a lot here in this middle section, which is the behavioral therapy and counseling that I'm sure many of you guys do out there, and treatment planning, the intake. All of these components are so essential, including pharmacotherapy, and then even more so these ancillary services that can help make holistic treatment be more successful. So I just want to point out that it is, in fact, accepted as one of the major avenues of treatment. But just like with any other substance use disorder, opioid dependence is no different. You have to make sure and individualize the treatment for that client who's receiving it. So there's no single treatment approach that's appropriate for every individual, and medication-assisted treatment is no exception. I hope I demonstrated that in the few case studies we just now did together, that there's no magic bullet here. There's a lot of things that need to be addressed, one of which are the biological things that are occurring in the brain that can be addressed on many different fronts, but it really is up to that prescriber and yourself and the client to discuss those options together to see what the best option would be. And there's really just no magic checklist of things to make sure they have in order to be appropriate or not. That's going to be an individual decision. You want to make sure when making that decision that you have a thorough and complete assessment so you can identify some of those things that may or may not knock them out of eligibility for these medications that I've described today. You definitely want to know about their history of drug and alcohol use and precipitating circumstances that led them into treatment and all the other things that you see on the screen that I'm sure you're doing anyway. It really can be helpful when you're talking about medication-assisted treatment for opioid dependence, especially ones that are going to have some physiological effect on their brain and not just like a diabetes medication that it just has side effects to it. This actually has an effect that you need to consider. And so things you might want to think about would be, are they currently dependent on opioids? If they're not, then they do not need to be taking methadone or buprenorphine by any means. And maybe they don't want to be treated with medications at all. Maybe they don't want to go into an office setting. They'd rather do it in more of a clinic. That's understandable. Maybe they have unrealistic expectations about the benefits that pharmacotherapy can give them, and they are offsetting that with downplaying the engagement in therapeutic process. That means they're not going to be a good and appropriate candidate for medication-assisted treatment. Maybe they're not capable of or willing to take the medications as prescribed. I mean, noncompliance is a real reason to consider not moving a client towards medication-assisted treatment. Maybe they're not psychiatrically stable enough. Maybe they're just abusing other medications or other drugs that would make them not be a good candidate for medication-assisted treatment for opioid dependence, such as maybe they're using alcohol or benzodiazepines, for example. Maybe they've had a lot of relapses, which is very frequent with this group. And so you'd want to make sure and discuss all the reasons the relapse happened and the growth that has come from each one of those to decide whether they're appropriate for these types of treatments or not. Maybe they're on very high doses of opioids and it's not appropriate at this time to prescribe them. Perhaps they have environmental conditions or some psychosocial conditions that are preventing them from using a medication. Maybe they're pregnant or nursing, in which case they'd be eligible most likely for methadone. Maybe they have experienced some seizures or they have HIV or hepatitis C or another infectious disease that would not be appropriate for these medications. And then finally, maybe they don't have a good support system in place to promote recovery. If that's the case, then they might not be a good candidate for these medications, especially things like methadone, because it can get you high. Buprenorphine can be a different way of initiating treatment or initiating a good support system along with Naltrexone. These medications work very differently than methadone does, so they have a different population of individuals that would make them eligible for that type of treatment. So finally, I just want to end on this 4 legs of addiction to get this image back in your head before I give some final closing remarks. So I want to burn this image of this chair in your brain if we can, because I just can't emphasize it enough. These biological components, that leg of the chair is so important, and we as addiction counselors have to step up and start recognizing it and treating that along with the psychological, the spiritual, and the social components. So with that said, that's all that I have for you regarding today's content. So let me just go over briefly a few housekeeping items in the last few minutes that we have together and before we close down. So some participants have already submitted some questions, so thank you for those, and we'll make sure and provide answers to all of their questions on our website. Just please give me just a few weeks to get these questions answered and posted. There's a lot that's been coming in. There's a lot on the line with us today. So just keep submitting those questions, and I'll tell you about some other educational opportunities. You may have noticed there was a lot of references within this presentation today, and that's because this is merely just an excerpt from a larger course that we have called New Innovations in Opioid Treatment Buprenorphine. That's also available as a home study course or a face-to-face training in your area. You can see all the different medication-assisted treatment products that we have through NADAC that have been independently developed by us to move opioid dependence and alcohol dependence treatment further along. So you can check out NADAC's online bookstore for a full description and for pricing of all of these products if you like it. And if you like today's presentation, like I said, this is a 1.5 hours out of an 8-hour presentation. So that new innovations with opioid treatment, buprenorphine, is a full 250-page manual that gives you way more information than I gave you today as well about this topic. And then coming up next month in our webinar series is challenges in identifying and addressing co-occurring substance use and personality disorders, and that's happening on December the 13th. This webinar and all of them in our series are available for CE credit and will be recorded should you not be available to attend the live event. So just check our website out for more details and to register. And there are many more educational opportunities and resources that are available on our website, including free online courses and face-to-face seminars and independent study courses. I encourage you just to set aside some time to browse and just take advantage of these free opportunities through NADAC.org. And you may have heard that Orion Healthcare Technology was awarded the preferred vendor distinction for NADAC and is our technology partner for this webinar series. Orion's been chosen as NADAC's preferred technology vendor in response to its dedication to providing quality resources and solutions to the field of addiction and mental health treatment. They provide the AccuCare web-based practice management system to help you streamline your workflow across clinical, financial, and administrative functions within your organization. You can visit myaccucare.com or call the number on your screen to learn more about this great product. And just one more time briefly for the latecomers, if you wish to receive CE credit for participating, you must pass the online CE quiz that's located at nadac.org/webinars or myaccucare.com/webinars. As soon as I finish speaking, I'll go ahead and put that link to the quiz directly into the chat feature for all of our live participants, and you can click directly on that in order to go get that CE credit quiz. And then certificates are free to NADAC members and AccuCare subscribers. Otherwise, they're $20. This applies to those who are logged in today for the live presentation and for those who are watching the archive version. So if you didn't get all of your questions answered on this topic, you're welcome to contact myself through the contact information on your screen. And then questions regarding AccuCare or Orion can be directed to Sarah, and her information is on the screen as well. So finally, I will send you a follow-up email soon that contains links to the PowerPoint presentation and the CE quiz and payment forms and the webinar recording. So just look for all this information in your inbox and your junk box. And when you close out of this presentation today, there will be a screen that automatically pops up that gives you the evaluation for today. We'd really love to hear your feedback on how I did personally and how you felt the content was being delivered and your feedback about the webinar series as a whole. So please give us that positive or negative feedback and maybe help us improve our series for today. So with that, I will conclude today's webinar. So thank you again so much for joining us, and I hope you have a great day.